आणि 4 पार्टिशन every year, a different day is announced by World Physiotherapy to celebrate World Physiotherapy Day. This year's theme is long COVID and rehabilitation. To celebrate this theme, the college is organizing various events that are rotary competition, speed play, and informative sessions. Now I request our first speaker, Dr. Aarti Shah, to share her expertise on need of pulmonary rehabilitation in COVID-19. Good morning. Am I audible?
Yes. Good morning. Just a second. Uh, so, congratulations to all of you. I think you people are the main people who are going to support uh, those who have suffered from I'm trying organizing committee to invite me here to be with you, and special thanks to Teen sir also. I don't think I need to talk much about COVID, right? Am I right? Yes. So, actually, technology. Okay. Uh, you know this character? Who knows this? Someone wants to talk about this character? Yes. आप देखते थे ना बचपन में छोटे थे तभी ये वाला देखा होगा कार्टून शो शी इज अ डॉक्टर ऑफ टॉयज राइट एंड इन कोविड आई थिंक एवरीवन इज अ डॉक्टर फॉर कोविड ट्रीटमेंट है ना but our role being a physicians being a physiotherapist is totally different right they know the things but we know how to apply practically use it right आपको बीच में yes या no बोलना है ठीक है so I start with a story as I know that to teach physiotherapy in front of you is a very difficult task for me okay here we are going to discuss some experiences some life stories and all so I start with this life story and this is about the COVID patient okay so he came to me after consulting many doctors you know ऐसे बहुत लोगों को मिल के आने के बाद में what people do let me see doctor what you can do for me right so what was his complaints what was his suffering he was hospitalized for more than 50 days you know more than 50 days must be ICU for a long time then stepped down for a long time then he was at home he was on oxygen therapy आवाज बराबर से he was on oxygen therapy and which were the complaints breathlessness cough body weakness and the most important thing he was not interested in the life so this is the main complaint I feel right am I right yes and was not able to restart his job that was the thing okay so here really I thought when he said that let me see doctor how you can help me and he consulted me after seeing me on some webinar or something like that so what is my role in this patient just to write some medication is it no so when he came to me okay so I need to diagnose him do I need to diagnose definitely having a COVID getting treated for COVID story doesn't stop there story starts after that Amit Dr. Amit sir का role हो जाता है then after that my role starts right and your role starts so then he came to me and like let me see whether he has pulmonary fibrosis or not initially when those two reports were published in the paper from KEN we were thinking oh every patient will have fibrosis That was our worry. Is he having pulmonary hypertension? Let me check it out. Pneumothorax, secondary infections, airway obstructions. Generally, what happens in this who has hyperreactive airways, if they have viral infections, they do have their allergy come and they have obstructive airway diseases. That is the story. And is there a bronchiectasis? So those were the thought because उसने बोल दिया था मैं देखता हूँ अभी आप कैसे हेल्प कर सकते हो, ठीक है ना? So what I have done? This is not helping me actually. I have asked for the past history. Many things were written on the files. 7-8 files were there. I was going through those files also. But when I asked him history in detail, he said that I was having seasonal variations. So you said that, ma'am, this is your job. Why you are telling this to us? But you should be knowing who is spending maximum time with the patient after a physician and relatives. You people are there. Okay? And you're knowing so many things because you're seeing them for half an hour, 1 hour, right? So I asked about the sleep cycle also. How is the sleep cycle? And a very surprising sleep cycle was there. He was going to bed at 2 a.m. in the morning and he was getting up at 10 o'clock. So being a chest physician, this is not good for the patient. Because we are sleep specialists also. We are more worried about that RAN sleep. We are worried about that NRM sleep. Okay, getting me? RAM में सपने आते हैं ना? सबको आते हैं? So, and as such major illnesses were not there. He was not hypertensive. As we say that COVID patients are there. अगर hypertension है, diabetes है, तो ही issues होते हैं नहीं. There are other things also. So on examination after seeing him, the pulse was very high. So he was on oxygen. He was taking oxygen for 16 to 18 hours. वो oxygen में क्या करते हैं हम लोग? How many hours we ask him to take oxygen? 16 to 18 hours. So that was going on. Treatment में कुछ कमी नहीं थी. Medication, the long list of medication was there. Yes, but physiotherapy was not helping. I think this is not helping me, huh? Okay, good. Yeah. Okay, go ahead. See, so respiratory was high, okay, and SVDU was 90% on room air, though he was taking oxygen at home. So that was like really, it was scary for me, right? आप क्या कर लोगे? ठीक है, मेरा इतना चालू हो गया था अभी. So, and he was having palliative interpretation, but I cannot show patient that me थोड़ा सा अंदर से लग रहा है. Can we show? No. Next. So, again I have asked him to go undergo some investigation. Next slide. So we have, yeah, सीधा treatment में चला गया. We go back, sir. So, back. So I have done X-ray test which was showing improvement. I have done CT scan which was showing resolving COVID. है ना? COVID का CT का report तो everyone knows how to read better than us. Patient knows मेरा COVID score इतना था, मेरा ये वाला इतना था, ठीक है? So I'm not going in detail of that. Then I have done his PFT, right? I was having only one scope that day. Other physician has not done the PFT. So I thought, चलो, कुछ तो मेरे हाथ में है. He was having severe obstruction with severe restriction with good reversibility. Okay, so that is a sign of bronchial asthma. Why he was not able to sleep in the night? He must be having some issues because of asthma. He was having seasonal variation. So that part was missed. And this was happening in the COVID because to spend time with the patient wasn't like, अरे कुछ हो जाएगा, right? So that was the thing. चलो, I thought वहाँ पे कुछ स्कोप है. So then other blood investigations were done. Those were okay. Then I started about treatment. So in treatment, what I have done, I have put him on inhalation therapy, which was not given. So good bronchodilator with the inhaled steroid I have started. Right? Oxygen therapy I have measured according to the ATG report. He was given for 16 to 18 hours, but he was told. He was told that how to take it, when to take it, and when to stop his oxygen. That was important. Then he was asked to go for physiotherapy. This is a multidisciplinary movement for a patient who is having post-COVID, right? They are saying that we should consult a dietitian, we should consult a physiotherapist, we should consult a rehabilitation person, we should consult a intensivist also, we should consult physiotherapist, physician, everyone. But is it possible practically? Yes or no? No, it is not possible. So who will play that role? Can you tell me? Who will play that role? आपको बताना है मुझे. You will play that role, right? Who is spending the maximum time? The maximum time. So along with the physiotherapy, definitely it is very important. You can guide him. Meanwhile, for diet also, basic knowledge everyone has. Then you can talk to him. You can be his counselor, right? So positivity should be there, but पहले positivity हमें होनी चाहिए ना. हमने तो सोच लिया था pulmonary fibrosis हो जाता है, अभी कुछ नहीं होगा, right? But the truth is not that. If you will go through this case, you will find so many things are possible with our and your support, right? So proper diet was advised, and he was psychologically continuously. I was talking with him. This is a video. Can we just? So after a treatment of 1 or 2 months, or like 3 or 4 months, I don't remember. Now he is talking about his experience, right? अगर ये play होता है. So when he lost the hope that he will not go for the job, what he is talking about the job. When he lost the hope that he will not walk, he has not gone out of his house for 6 months. Okay? Okay. What he is telling? He is a teacher. Now he is able to go to the college where he has to climb fourth level. He can go. He is able to talk for 1 hour as a teacher. He is going for his lines of functions and all. So is that enough? Yes, that is enough. And oxygen is started. So what minor changes we have done along with the physiotherapy? Small change in the treatment. But the major part was done by whom? You people. Right? So this is very important. So now we talk about long COVID. This time's theme is long COVID. So long COVID में क्या आता है? Can anyone tell me? Yes?
Symptoms will be fatigue, dyspnea, brain foggings, and smell and taste loss will be there, and followed by hair loss, like all the symptoms.
So everyone knows about this, right? Long term, यानी कितना long term? That is the question. Anyone knows about that long term? More than 200 symptoms are there which can be there. Maybe a year. I mean, how many like months you feel like as per your reading?
3 months.
3 months minimum, and then it can be for a long time. Still the studies are going on. We are conducting one study in which we may be able to publish the data. And one of our article is showing that 1 to 2% of only respiratory patients were there who were having COVID, right? So that is there, but always when you will go for your visit, what will you see? Go and see the PRP, right? Because they say that most of the patients had DLCOP defect. एक्सरे नॉर्मल है, काफी अच्छा है, सीटी रिजॉल्व नहीं है, पीएफटी का रिपोर्ट भी ओके है, बट द इशू इज देयर इन द alveolar level where the transmission of oxygen is not there. So go and see that. So then what we you will say that no, patient is having issue. It is not psychological. Because we are saying that they are having foggy, they are having negative thought, but we need to check certain reports. You will be having time for that. 20% have airway obstruction. We had that patient, right? And 20% had restrictive lung disease. अगर आप बोल रहे थे कि सारे पेशेंट्स को फाइब्रोसिस होगा ओवर इन द आईसीयू, तो 20% को नहीं आता था. There would have been many reports with the restriction. So it is not like that. In OPD basis also we are not seeing those many patients. Pulmonary fibrosis. In whom it will be there? 4% of the patients with the disease, duration of 1 week. More the duration, more the chances. Okay? So when you will go and see the patients, you go for the visit, you have to see the duration also. That is what I want to tell you. So that you will be able to think that, अरे fibrosis तो नहीं हो रहा है. How much percentage of fibrosis there? Let me talk to the consultant. Does the treatment changes from your side if the patient is having pulmonary fibrosis and who is having COVID? On one side and other side, the simple patient who is having IPF, treatment different होता है COVID IPF और COVID fibrosis and routine IPF में? Yes or no?
Yes.
Different होता है?
Somewhat different.
Somewhat. सर ने perfectly बोला somewhat. क्योंकि यहाँ पे थोड़ा दिमाग में powder भी होता है. यहाँ पे पता है routine patient है. But main treatment is what? Physiotherapy. Antifibrotics we give, but उसका भी time होता है. Up to some months has an effect. But for lifelong, what is the main thing? What is there in the treatment? That is physiotherapy and physiotherapy. Knee strengthening and many more. Don't ask me in detail, I don't know. Okay, so this is a picture which is showing that where is the issue. Can you see? There is down alveolar wall thickening is there. There is the issue. दिख रहा है? I don't want to touch this. अगर फिर से कुछ change हो गया तो. So that fibrosis is there which is not allowing the transfusion of oxygen. Blood में जाएगा oxygen तो नहीं जाएगा अगर आपको रास्ता नहीं है. ठीक है? That is it. Any queries up to this? Clear? I want to tell you where your role is there. I'm not done anything. Okay. So treatment physiotherapy that we have already discussed. Antifibrotic, bronchiectasis. How will you come to know that patient of post-COVID is with you is having bronchiectasis? क्या होगा हिस्ट्री में? I know this is not a lecture, but still expectoration आ सकता है. अगर dry bronchiectasis होगा तो नहीं आएगा, but coughing will be there, continuous coughing will be there. So you can check the reports. Go to the CT scan. Talk to the physician. Do I need to change my treatment? That will be there, right? Mostly the lower lobes are involved. They say that there are many case reports they have published. You know that more publications are done in COVID than other subjects. Pulmonary hypertension. How will you come to know that patient is having pulmonary hypertension? Consider this patient. If this patient is referred to you, he may have idiopathic for a long time. Don't go working hard. आधे घंटे से ज़्यादा फिजियोथेरेपी दे रहे हो, RT is getting proper treatment, then also it is not working. So let us see the today report. You can talk to doctor. Doctor, I am saying that edema is not getting reduced. Nutritional issues are not there. He is taking proper food. Hyperproteinemia may be not be there. So can we go for echo? Let us see how much is the pulmonary artery pressure. The small change in medication will help. So these are the things which you have to keep in the mind, right? So these are the references as an evidence-based medicine we are practicing. I have kept them. I don't need to go in detail of that because details will be taught by other speakers. And and you people know. Thank you. Any questions? Okay. Thank you. Thank you, ma'am. Now I invite Dr. Neha Mutala to give a certificate of appreciation to Dr. R.T. Shah. Now I request our speaker, Dr. Hamid Chauhan, to share his expertise on physiotherapy as an adjunct therapy for COVID management in ICU.
Good morning, everyone. First of all, happy World Physiotherapy Day. And I would like to thank Department of Physiotherapy and organizing team to inviting me for this talk. And believe me, you have already worked very hard in this COVID during first wave and second. We have witnessed. They are continuously working in ICU. So we have seen you people doing very great. Heads off to you. Now coming to my topic, so I will be talking on physiotherapy as an adjunct in COVID ICU. Now I will be starting with a case scenario. Again, madam has already given one story. So this is the arbitrary case. We have a 55-year-old male, known case of hypertension, diabetes, presented with a high-grade fever, vomiting, generalized body ache following the day. He noted increasing difficulty in breathing. On examination, there was a fever of 100 in Fahrenheit, tachycardia 104 per minute, BP was 140 by 90, respiratory rate is 30, and SpO2 is 90% on room. So, which category? Is it severe patient? Does this patient require ICU or not? Yes, maybe yes, because SpO2 is already 90% on room air, and dyspnea is there. Respiratory rate is very high, so respiratory distress is already present. Now, on investigation, where COVID RT-PCR was positive, inflammatory markers like D-dimer, CRP, LDH was raised, lymphopenia was present, and on initial chest X-ray, there was bilateral infection. So this is very important. They have divided into the three categories: mild, severe, and critical cases. So in case of mild cases, they doesn't require hospitalization, and rest 20% of the cases they need hospitalization as well as at some point of time ICU care. So let us see when to label the patient as a severe illness. So we know that SpO2 less than 94% on the room air, the respiratory distress with respiratory rate more than 30 breath per minute, PF ratio less than 300, and lung infiltrate more than 50%. And these patients may experience rapid clinical deterioration, so immediate treatment or intervention is needed. Because this patient can worsen anytime. This was the initial chest X-ray. There are bilateral diffuse infiltrate, which in subsequent X-ray increased up to whole white lung happened in this patient. And this was the initial CT scan with a round glass appearance with almost 40% lung involvement. So let us talk about in brief regarding the treatment or principles of the treatment. So you should know the general principle of critical care. So I will not go into the detail, but this thing you should know. So first of all, airway breathing and circulation. You have to stabilize airway by clearing the airway if secretion is there. Breathing, you have to put oxygen. If respiratory distress is there, you have to think for some other therapy like BiPAP or high flow oxygen and circulation. Not specific drug. Now this is the third thing. Rehabilitation and physiotherapy is very important in ICU. Almost each patient needs physiotherapy at some point of time. So almost every patient will need physiotherapy, and you might be having a reference of almost all patients. And you have done physiotherapy in almost all patients, right? And lastly is to treat and prevent complications. So there are these are important complications like ARDS, septic shock, cardiac dysfunction, elevation in cytokines, thromboembolic event, and exacerbation of some underlying coma. And they also present with different multi-organ system failure like hepatic involvement, renal function involvement, and CNS. So next, why we need physiotherapy in ICU? Basically, we will talk about the goals. Why we need this in ICU? So to improve the lung function, this is very important because in COVID, lungs are involved very badly, and decrease the patient dependency on ventilator and improve residual function. Then limit patient morbidity and mortality. Optimize ventilation and oxygenation, reduce number of hospitalization days, and reduce the complication and improve quality of life. Last line, improve quality of life is very important. And it is just post ICU care. If patient discharged from the ICU, then this is very important. So now what are the concerns in the ICU? So if patient with a COVID admitted in ICU, there will be physical deconditioning, neuromuscular weakness, fatigue, impaired lung function, there will be delirium and different cognitive impairments, difficult in swallowing, communication, mental health disorder, and constant need of psychological support. Because these patients are very depressed. If someone comes with a COVID positive, so first of all they think that what? जोर से बोलो.
Nobody will come to them to talk and
Patient and family will be tense because there is no guarantee whether you will be there or not after 15 days. Now, generally, physiotherapy roles comes into these two stages: in acute stage and post-acute stage. As far as ICU is concerned, so you can say acute ICU stage or post-ICU stage, right? So in acute stage, objective would be optimize oxygenation, manage secretion, and prevent complications. Here it is a multidisciplinary approach. Many consultants like respiratory specialist, intensivist, physician, physiotherapist, nursing staff, everybody is involved equally. And the problem setting would be in ICU only. And when this patient discharged from the ICU, then post ICU care will be needed in step down unit or ward. Now coming to the recommendations. So we will not talk about the detailed procedure, how to perform, what type of procedure you perform, because you already know the procedures very well. So and I have no experience in physiotherapy. So these are the recommendations taken from the American guidelines and Australian Physiotherapy Association guidelines. So they have divided recommendation into three categories. First of all, recommendation for physiotherapy workforce planning and preparation. Second, recommendation for delivery of physiotherapy interventions, which is further divided into three: physiotherapy for respiratory interventions, recommendation for mobilization, exercise, and rehabilitation interventions, and lastly, personal protective equipment for physiotherapists. And last but not the least, recommendation when not to intervene. They are not. This is not a recommendation, but I want to like to add this because when not to intervene in ICU, that is also very important. Now coming to first recommendation for workforce planning and preparation. So there is a very long list of recommendations are there in the guideline, but the more easy one and most important one I have just summarized here. So first is plan to increase number of physiotherapists or staff in ICU before, and that we have already done. Means in phase 1, wave 1 and wave 2. Many physiotherapists, many nursing staff already been recruited, already been working in ICU, and staff has already been mobilized. Second important recommendation is most experienced and skillful person should be there in the ICU. If suppose the senior most physiotherapist or most experienced in ICU should be chosen for the ICU. The non-experienced or junior staff, they are recruited as a supporting role under the guidance of this experienced one. Fourth thing, they have recommended to do regular education training of the staff. Either e-courses are there, where there are lectures, there are clinical meet simulations, etc. And lastly, the whole team, physiotherapy team should know actual treatment guideline and protocols for the patient, because it is also important. Because you should know, in short, in brief, you should know whether what treatment is going on, what are the treatment, what are the protocols. Now coming to recommendation for physiotherapy respiratory interventions. So in this, there are something called screening recommendation for physiotherapy. So we already know that there are mild cases, severe cases, and critical cases. So they have given recommendation, or they have even categorized into when to do, in what type of patient one to physiotherapy is required. So first of all, mild symptom without any respiratory compromise, there is nothing, no physiotherapy reference is required. Means physiotherapy is not, and home treatment is okay. Now pneumonia presented with feature, low oxygen requirement, oxygen flow less than 5 liters per minute, and non-productive cough, and patient able to clear secretion. So again, physiotherapy is not required. Now coming to proper ICU part. Again, these are mild symptoms with comorbidities, either respiratory comorbidity or neuromuscular comorbidity, like cystic fibrosis, neuromuscular disorder, spinal cord disease, bronchiectasis, etc. Here, physiotherapy is needed for every case. And keep in mind that airborne precaution to be followed. And patient must wear surgical mask during physiotherapy. Last category in this is the exudative consultation. There is a productive cough, pneumonia, and patient is inactive. Patient is so fatigued that patient cannot cough. So in that case also, physiotherapy is required. Now coming to the severe symptoms. So here we know that increasing oxygen requirement, fever, difficulty in breathing, respiratory distress. Here directly physiotherapy referral is required. So for every clearance, because they have weak cough. Again, airborne precautions, and patients should wear surgical masks. These two categories of patients generally treated in ICU or high dependency unit. So here always physiotherapy has an important role. Now these are the recommendations. After screening, these are the points to be noted. The personal protective equipment is recommended to assure airborne infection and precaution for your safety. Right? You all know how to wear PPE, right? You have done already. Second, continuous assessment and evaluation of the patient. Means you have to monitor vital signs, what treatment is going on, what are the phase, whether you have to decide physiotherapy is to be given or not, and you have to consult the concerned physician or ICU physician whether patient is stable enough to have a physiotherapy session. Right. Third, reusable respiratory equipment should be avoided, and if patient on ventilator, there should not be a disconnection. If ventilator is added to the patient, you should not disconnect the patient for either for suctioning or any therapy. Closed suction is recommended. Right. And lastly, aerosol generating procedures should be avoided. Right. What are aerosol generating procedures? Anybody? Sneezing, coughing, that is patient's right. Other? Any procedure related, physiotherapy related? So this is a list. Means aerosol generation can occur either from the medical part of treatment, like device and procedures, from physiotherapy, exercises, and mobilization. So there are few: high flow nasal oxygen therapy, BiPAP, lung recruitment manual, nebulization. In case of physiotherapy, there will be diaphragmatic breathing exercise, pulse breathing exercise. These are all aerosol generating procedures. So you should avoid this procedure to prevent infection to others. Or either you have to wear the PPE kit and you have to maintain airborne and droplet precaution. You have to use negative pressure rooms and with minimum staff. So danger of that to other staff is prevented. Now tracheostomy management. Again, secretion, suctioning. Again, you don't have to detach the ventilator during suction, right? And tracheostomy care. After tracheostomy care, speech therapy to be avoided after acute phase of the treatment. Means acute phase of the patient, if patient is stable and patient is discharged from the ICU, then you decide for the speech therapy and other therapy. Now coming to position management. All COVID patients are generally nurturing which position? Prone position. Prone position is recommended in all patients should be prone in COVID ICU, right? Or if patient is awake and stable, head up position, 30 to 45 degree head up position is needed. Respiratory exercise may be considered like deep slow breathing and chest expansion breathing can be done. Otherwise, pulse sleep breathing, inside spirometer, bronchial hygiene, re-expansion technique are not recommended because patients are not stable. So if you do this, then patient will be fatigued and respiratory distress will increase and there will be very lot of complications. So this is a typical process of the coding. So you know how to clone the patient. So you need many staff, at least 6 people is needed to clone the patient. And this is a typical photograph of how to do coding. This is not intubated patient, but even in intubated patient, the method is same. Only thing you have to keep, you have to secure the intubation EPDU and all lines. These are the postural drainage. Different segments of the lung or bowels can be covered. Secretion can be removed with this postural drainage. And how to know which lobe is involved? How will you decide which posture is required to drain the secretion? Concentration, right? For the lobe, you have a CT scan. CT scan is there. You exact where it is available, where the secretion is there, where the downclass activity is there. We come to know. Now coming to recommendation for physiotherapy exercise. So here first important thing is infection. The infection control precaution should be followed. Then training of skeletal muscle and maintenance, recovery of all activities of daily living are contraindicated in acute phase. When patient in ICU, patient is not stable, hemodynamics is not stable, patient is on ventilator, patient is totally knocked down, then this skeletal muscle exercise is not right. Exercise management may include passive range of motion and therapeutic positioning if patient is unconscious and unable to move his or limb in order to prevent ICU complications. Which complication? Which complication commonly occur due to immobilization? Pressure source. Then DVT. DVT is very important. Now, according to type of intervention and intensity, timing modality should be tailored according to individual need. Now, like severe critical illness, obesity patient, elderly patient, there are complications. So you should titrate whether patient need this type of intervention or not. And also intensity of exercise should not be very hard in the ICU. Otherwise, patient will be fatigued, respiratory distress will be there, and there should be a continuous assessment and monitoring of the vital signs. Last, extra care must be taken for the patient with mechanical ventilation to maintain ventilator circuit during exercise. Now coming to infection control recommendation, only this is also a long list, but all physiotherapy must be trained for correct dosing and doffing of the PPE. Droplet and airborne precautions are important. Now this is the last slide I have added from the Middle East paper from some paper from Middle East. So they have divided the COVID physiotherapy into the categories. So this is not a good resolution actually. Resolution is not good, but they have divided into 3 categories: intubated, sedated, and paralyzed patients. So for that, they have goal to minimize complication of prolonged recumbent position and to facilitate oxygen. These are paralyzed patients basically, whether on ICU, ventilator, ECMO, all patients are in prone position. So these patients, so these are the goal. So again, we will find some role of physiotherapy here also. because of positioning, secretion, drainage, and they have other category 2. They are also intubated patient and they are on minimum sedation or sedation back-end. Here, patient is not completely paralyzed. Right. So again, to minimize complication of prolonged recombinant position, to facilitate oxygen, and to improve functional dependence. And category C are non-intubated. So non-intubated you already know. It is just a post-ICU care or routine physiotherapy session and rehabilitation to be done. Now last take-home message. Number of supportive staff is very much needed to deal with the flu that you have already witnessed. Right. And challenges are due to patient instability, paralysis and prone position. Prone position is very difficult and many staff is very much needed and experience is must. Experienced staff is needed, otherwise complication will occur. And physiotherapy is essential both in acute respiratory phase and to support rehabilitation. Organization and planning are the key to the success that all administrative of each country, state, they have already done. Rehabilitation is also needed following the discharge. Thank you. And again, happy World Physiotherapy Day.
Thank you, sir. Now I invite to Dr. G.T. Kumar to give the certificate of appreciation to Dr. Amit Chauhan. Thank you, sir. Now I request to Dr. Halina Gupta to share her expertise on long COVID and role of physiotherapy. A very good afternoon, everyone. And we all have been gathered here for the celebration of World Physical Therapy Day. So, congratulations to everyone once again. Now, the topic is long COVID and role of physiotherapy. I think this term is actually circulating in the internet too much from a short span of time. So, talking about the long COVID and physiotherapy, long COVID and physiotherapy. So if I say that when a person gets infected with COVID-19, what exactly is happening? We are seeing a lot of variation in individuals' recovery. Either they are getting recovered within few weeks or they are taking time with the recovery. Some recover within 1 month, some recover within 3 months, and there are some people where the recovery is actually, or the symptoms are actually lingering on for long period of time. That's how the name actually has come up with a long COVID. The long COVID, if I say that, it is synonymous with post-COVID, post-COVID-19, post-acute sequelae of COVID-19. So these are the various terminologies which has been given by various countries. So, before I actually proceed with the long COVID, we did a small, there is a small unpublished work for which we had done within our college premises. So we actually contacted the people who actually had COVID-19 and they have been recovered. So there were only 46 individuals whom we had interacted with them, and we found that the fatigue was the most disabling symptom which was present in all of them. Even after 1 year of their COVID-19 recovery, the fatigue was something which was present. And it is actually in agreement with all the published data which we have right now available with us. So going on back to the long COVID, it's an umbrella term that may include a permanent organ damage, post-intensive care syndrome, a post-viral fatigue, and very importantly, it has a prolonged multi-system involvement. So actually, the COVID has not left any system. Cardiovascular, neurological, respiratory, gastrointestinal, renal, metabolic, and other systems. I think many of you might be aware of this thing, but I'm just again going into the more depth of this long COVID. Now it is not wise to think that I had a mild COVID symptom, so probably I will not get long COVID. Long COVID can affect any person, irrespective of the severity of disease, whether it was mild, moderate, or severe, whether they were hospitalized or they were not hospitalized, they can have COVID-19. And it is also the long COVID is also irrespective of the age. Symptoms change, they come and go, they fluctuate, and they are multidimensional, episodic, fluctuating, unpredictable. Okay? So the symptoms, when we talk about the symptoms, there are various symptoms available. As even Aarti ma'am recently mentioned that there are more than 200 symptoms of long COVID which are available. But the few which are most disabling are the overwhelming fatigue, dyspnea, brain fog, patient complains sometimes of a bradycardia, sometimes of a tachycardia, sometimes they have a gastrointestinal issues. So I will share my experience that when I had COVID in the month of March, I recovered in April, and then I think, alternate day or every week I was actually visiting the doctor and saying, I'm having this problem, I'm having that problem, I'm having this problem. So he was like, don't worry, 3 months, you will have something or the other symptom coming up. So just wait for 3 months, let's see that, 3 months, you will have something or the other coming up. That is what he said. So I was happy. Okay, after 3 or 4 months, I probably will be fine. But now there are cases which are coming even after 6 months, the patients are complaining of fatigue and they are coming up with a new symptoms. So it is something very unpredictable, something yet not known to the clearly to the fraternity. So if I say long COVID, it's an emerging condition, not yet understood, risk factor not known, who will recover from long COVID, not known, what strategy will work better, not known. We do not have a consensus for the definition yet for the long COVID. Some says it is after the onset of 3 months after the onset of COVID-19 infection. Some says beyond 12 weeks after COVID infection, and there are some who say that we can have the three categories till 1 month, 4 to 12 weeks, and then we have more than 12 weeks, so we can have the category. We still have not come up with we have not come up with any consensus of the definition yet. Though it is another with post-COVID. But I think the post-COVID and the long COVID is going to be a separate entity probably in the future. So coming on to the role of physiotherapy. So what exactly is the role of physiotherapy in long COVID? While I was searching on various studies or various informations available on the internet, I actually came across that normally what we say, the pulmonary rehabilitation, which is very important post-COVID, and we say you have to gradually build up your stamina, your fitness level, you have to prevent deconditioning, you have to condition yourself. But the latest article which has been published by the WCPT is it is right to go ahead with all these things, but you have to be cautious. And why we need to be cautious? There is very important thing which they are actually suffering is fatigue and exhaustion. It does not result from any unusually difficult activity. I have done something too heavy today and I am feeling fatigued. I might have done something very minute, something I have done but I am feeling too fatigued and today. I am unable to perform any sort of activity. I talk for a longer period of time, I am unable to concentrate. I am having memory issues. In other words, I feel that I am totally drained off, I am crashed, I am shut down. Whatever the languages many of the people have experienced, they have described that I am unable to do anything and I just want to lie on my bed. I just don't want to move anywhere. So these are the very disabling symptoms which is actually majority of the people of long COVID have experienced. Now the WCPT side or the WHO guidelines have come up with many assessments where we need to ask the person what they are feeling because the symptoms are individualized. It is not same for everyone.
We have many questionnaires like deep or symptom questionnaire. We have many cardiopulmonary exercise testing, 6-minute walk test, which needs to be performed before we put them into some exercise program. Not that a person is fatigued and you say that okay fine, don't do all the major work, don't do big exercises, just do light exercises. No, I need to assess my patient. I need to check this, go for the exercise testing, go for the 6-minute walk test, just see his vitals, just see his parameters, just see how much recovery he is taking to recover from all these things, and then probably manage his symptoms using energy conservation techniques, using a pacing program where he should have an adequate balance of activity with rest. So not taking much time, I would say that I came across 3 articles on this pacing where these were the 3 I'm not saying slogans, but the 3 mnemonics which I really like. Keep pushing yourself. What happens is, I experienced this and I used to feel very dull. People used to tell me, push yourself. Don't sit idle. Push yourself. But keep pushing yourself is not the answer. Okay? You have to stop. You have to take rest. You have to pace. And in pacing, you have to plan. I have a reservoir of energy available with me. With that reservoir of energy available, what activities I need to prioritize, which I should finish first and then probably go ahead with the other activity. It's not that I have done something, I wasted my whole energy, and in the end, for something important, I'm left with nothing. So these are the 3 things I think you may not remember what I'm speaking, but probably you may remember these things that if there is a fatigue or exhaustion, you need to stop, you need to rest, you need to pace. And in pacing, you have to plan and you have to prioritize. Okay? Very important thing, which is again, there are many things happening on the internet about the heart rate monitoring, where physiotherapists again have to intervene and come into the picture. Because you somehow have to make sure that your patient is not working to a level where he is totally exhausted. So you have to plan his target heart rate, you have to plan his threshold beyond, above which he should not work. So there are many Workman Foundation has proposed many authorities. So what I'm trying to tell you is that it is not that a patient is coming and I'm giving some exercise program. I have to, as a physiotherapist, assess my patient appropriately and then plan his treatment based on what I have found from the various tests. Relaxation techniques, listening and listening techniques, I think I do not have to talk much about it because you all must be aware of. And very important is you have to prevent deconditioning and improve the fitness levels. I have not added the pictures of exercises, the stretching and aerobic exercises, which we all know that we have to do. But what I want to emphasize here is that going on to the fitness level has to be gradual. Right? Going on to the fitness level has to be gradual. There are studies who are saying that in 3 months, once you have recovered from COVID, you must not do vigorous activities, you have to go on gradually and do it. What is important here is rest, wait, observe. Once I have given a plan to my patient about some exercises, maybe it is a sub-maximal strength exercises, maybe it is an aerobic exercises, I have to wait and watch whether his symptoms have not exacerbated, whether his symptoms have not increased because he has the issue of fatigue also. So then I need to wait, observe, and probably change my plan of treatment which I have decided for. Okay? So it is very tailored, very individualized treatment which we have to actually take our patient with a heart. Now I'm not talking much, but yes, there are disproportionate breathlessness on exertion patient may complain of, inappropriately increased heart rate, tachycardia or a chest pain. But yes, as Aarti ma'am has already been said, that it is not, it's a multidisciplinary approach. Not everyone can do everyone's job. Where I need that this person need to have a cardiac screening or need to have a screening from a pulmonologist, I need to refer my patient to them and probably screen them for the activities before I plan for any of the activities. So this is what I really want to emphasize here. And exertional oxygen desaturation. So now they are also recommending that when a person is doing exercises, the pulse oximeter should also be there to check for his oxygen saturation because sometimes they get desaturated. And if there is desaturation on exertion more than 3%, which sometimes considered it as a red flag also, and you will not go ahead with the exercises to that extent. So very important here is nose, low and slow. I really like when I was actually preparing this, I really like these mnemonic because these are something which are good, easy to remember and it has a lot of evidence behind it. Inhale, exhale through nose. Low is a diaphragmatic breathing and slow is your process of breathing has to be slow. So you probably have to focus on the slow breathing pattern. So this is again, I think it's a British Association has given this rectangle shape where which you actually can, as a feedback to the patient can be given. So he has to look into the width of the rectangle when he's breathing in and the length of the rectangle when he's actually breathing out. Okay. So there are various tests for this. This is the last which I really want to talk about. Dysautonomia, where dysfunction in the autonomic nervous system. So we even have various tests to actually see that. POTS, P-O-T-S. I guess many of you must be aware of this terminology, which is postural orthostatic tachycardia syndrome. So when they change their positions, they have an increase in the heart rate. So POTS. So again, we have to go for autonomic conditioning therapy. I may give exercises first in the supine position and then probably see how he gets accustomed to the various positions and then probably add on to the exercises in sitting or in the standing position. Isometric exercises, utilization of non-upright position exercises and patient education for the safety, which is very, very important. Okay. I have not spoken much about the things which probably you know that these are the physiotherapy things or my exercises, my breathing exercises, my distal imaging techniques. But what I really want to emphasize in today's lecture is that long COVID is still not understood. I have to be cautious whenever I'm planning for certain exercises based on my assessment and based on my evaluation of the patient. So there are more than 200 symptoms reported in long COVID, commonest being fatigue, shortness of breath, and the brain fog, right? And one must seek help of a physiotherapist if there are impairments leading to activity limitations and participation restriction. So with this, I think but we have to create an awareness because not everyone knows that probably our role changes with every stage. Our role changes. Our role does not remain the same. What we had in the hospital, what we had after discharge, post-COVID, or probably the long COVID or the long hauler syndrome is again another term which has been used. With this, I end and thank you so much and wishing you once again a happy World Physical Health.
Thank you, ma'am. Now I invite Dr. Megha Mehta to give certificate of appreciation to Dr. Narina Gupta. Now, I request our speaker, Dr. Kalpesh Ratani, Associate Professor of
College of Physiotherapy, Sumande
Vidyapit, to share his expertise
on pulmonary rehabilitation in COVID-19.
Yes, very good afternoon to all the attendees, Dean sir, Dr. Aarti and Dr. Amit. Yes, before starting, let me say congratulate everyone because we are celebrating World Physiotherapy Day. Yes. Second thing, I want to thank Dr. Aarti and Dr. Amit for recognizing our role as a support member during the tough time we had during the second wave. First wave also, but second wave was a tough time. So thank you very much for recognizing our role. Now, coming back to my presentation. Now, whatever I have prepared in this presentation actually came from my PGs who have worked very hard in the wards and ICUs. Those second PGs are not there, second year PGs who are having exams. But again, the major source of this presentation is from my postgraduate students who actually work very hard in the ICU as well as in wards. And you might not feel that there is something new in these slides, because I was told that whatever we have done in our hospital to manage COVID, I have put it over here as a summary. And due to time constraint, I have put mostly summary points only. So it is all the things what you have done. Yes. Now I think everybody knows what is COVID, what are the symptoms of COVID. So I will not go further. But we need to know that COVID may lead to fibrosis, obstructive airway disease, as Dr. Aarti said, bronchitis also. So we need to know while managing this patient that this disorder patient should not have. Okay. Now, important thing is when the patients are in the ICU, and if the ICU stays longer than normal, then patient might have, not all the patients, very 2 or 3% according to the research. Post-intensive care syndrome is also there in some of the patients who are having a longer stay in the ICU and probably to whom who were intubated. Another thing is post-viral fatigue syndrome is also there. Okay. So it is our role as a physiotherapist to restore function to pre-morbid level by giving adequate and timely intervention. What we did. Now that's what our role comes. So pulmonary physiotherapy or pulmonary rehab. We need to think, and we thought also that the COVID-19 is a kind of restrictive type of problem. Though later on it might be causing obstructive airway disease, bronchitis, but predominantly it is a restrictive type of lung pattern. It leads to fibrosis and ultimately sarcopenia, that is chronic skeletal muscle weakness, loss of muscle mass, and ultimately loss of energy to continue routine daily activities. So pulmonary rehab is very important for this patient for recovery. Now, before enrolling the patient, we need to assess the patient. I think everyone knows that we need each and every patient to be assessed because each and every patient is unique. They may be having a similar problem, but may not be having a same problem. So each and every patient should be assessed vitally as well as in other things. And I think the patient, when they were admitted, they have already been screened by pulmonologist, physician. So they have told us to start physiotherapy. So we consider at that point of time during physiotherapy that they have already screened. Other thing is advisable to have a physician. Now, while working, there were already respiratory medicine people. So we were actually happy that they were there. So while giving physiotherapy, whatever untoward things happen or will happen, we can directly consult them. Now assessment, as I told, unique to each and every patient is very important, as it will help us in monitoring the progression as well as it will help us for supervision of the problems of the patient, and it guides us for further rehabilitation. Means when to change the program, whether to increase the intensity, increase the repetition, that rehabilitation will guide. So history of COVID, as Aarti Madam already told, that incidence of fibrosis depends upon the days of diagnosis. As the days after diagnosing of COVID is increases, chances of COVID-related fibrosis is also increasing. So date of diagnosing is very important. Apart from other things, vitals, again SpO2, most important parameter. 6-minute walk test. Yes, in a ward patient we tried to do 6-minute walk test, and again the patient who had not completed 6-minute walk test, we came to know about their vitals, their reason for not completing, and the patient who were find it difficulty in walking continuously for 6 minutes. Though we did not perform 30-second sit to stand test or a 30-second wall push-up test, but we could have performed, because recent evidences which I am going to show you, these evidences are saying that if patients are unable to walk or lack of energy, or having a deconditioning effect. So rather than performing 6-minute or symptom limited walk test, we can perform 30-second sit to stand test as well as 30-second wall push-up test also. Now we'll move towards the main part. What is our main goals? Now there are multiple goals, but at that point of time when the patient is COVID positive in the ward or in the ICU, hospitalized, maybe on oxygen therapy, that time primary, at that point of time what is our rule is, first thing we should prevent complication related to prolonged recumbent position. Because when the patient is hospitalized, they think that I am hospitalized, I need to take rest. But here in a COVID, it is not like that. We need to prevent complications related to rest or related to prolonged recumbent position. Plus, along with the promoting or along with the preventing these complications, we need to promote or facilitate oxygenation. Like how we can promote oxygenation? By limiting development of fibrosis, by removing secretions probably, and by giving exercises like deep breathing exercise to maintain or to recruit alveoli each and every time when the patient takes deep breath. So our primary aim was that each time patient takes a deep breath, each and every alveoli should recruit and should participate in oxygenation. And all these things occurs automatically, recovery, functional recovery will be there. The important thing which other speakers have also pointed out is we need to start very slowly as all the patients were positive, and we need to progress very slowly. This is a very important thing. If the patient recovers fast, that doesn't mean we should give more vigorous exercise to prevent post-discharge complaints. No, we need to start very slowly and we need to progress also very slowly and gradually. Now, yes, this article published in NCBI, the study done was on guidelines of physiotherapy management in acute care of COVID dedicated hospital. That was done in Mumbai. Okay, they have recommended certain things. They told that physiotherapy is effective, chest physiotherapy particularly, including chest expansion exercise, that is what thoracic expansion exercise. In fact, they have recommended incentive spirometer also for selective category of patients, not all patients, as Dr. Amit already told that aerosol related precautions. Okay, the infection can spread to the respiratory staff, but the thing is, everyone who was working in the COVID was wearing PPE kit. They knows how the COVID spread, so they themselves were taking COVID related precautions. So again, incentive spirometer also they have recommended. Now, everyone knows that in the second wave, first wave also prone position was there, but in the second wave, particularly when it was widely used, there are many researches which right now, and I searched, there are many articles on prone therapy, though the COVID is relatively still new, but there are numerous articles on COVID therapy. So even we tried also in patients who are not having any symptom or minimal symptoms, who were on 2 to 3 liter oxygen therapy, nasal cannula, face mask. We have given a prone therapy and we have seen a good result. Now again there are various articles. Again this article was published in NCBI and this was a water-cooler publication, proning position or a prone position in non-intubated patient with COVID-19. So in this article they have stated that how COVID-related prone position in COVID patients, how it is helpful. And again, the proning position, as Dr. Amit told, we need a team to rotate the patient who are on mechanical ventilator. But again, the patient who are on oxygen therapy, the patient who were not on oxygen therapy, actively moving in the ward, they were actively doing the proning therapy and they also found it very helpful. Another article, prone position in the management of COVID-19 patients. This was a multi-center study and I think they have taken 9 centers, and in this commentary what they have told that each 9 centers they found beneficial effect in by giving proning position, and the most important effect was reduce dependency on oxygen. And all of you knows in a second COVID wave, though in our hospital there was no restriction for oxygen availability, but again, you must be knowing that there was very scarcity for oxygen. So this commentary says that proning therapy was very much helpful in reducing oxygen dependency. Now, how, according to this article, what they stated in the conclusion is this prone position can recruit dorsal lung region. That is what the main region for gas exchange. Okay, it increase and expiratory lung volume. So if the end expiratory lung volume is increasing, the alveoli can remain recruited or open during expiration also. So it will not close completely. Third thing is increasing chest wall lifespan. That is also very important thing. It decreases alveolar shunt, improving tidal volume. And another thing, one of the meta-analysis is also there in a proning position. In this 1.5 year of COVID, we have a meta-analysis also. That was done by Munshi. And what is their conclusion? You don't believe this prone position independently, of course, along with the medicine, but independently in terms of physiotherapy, other physiotherapy, can reduce mortality of the patient. That was creating havoc during second wave because most of the people, not most of the, many of the people have not survived in this COVID wave. But this meta-analysis says that prone position independently can reduce mortality. Now, thoracic expansion, I know everybody had given it, and there are evidences also. Yes. Pulmonary medicine and rehabilitation and pulmonary rehabilitation for COVID-19. This article says everything what we have tried during the second wave: thoracic expansion exercise, breath control exercise. Some of the patients were having an incentive spirometer. Okay, and of course, percussion vibration, that was not given to each and every patient. That was depending upon auscultation finding, as Dr. Amit said, CT scan, which all the areas were having consolidation, secretion collection. So this article is backing all our effort, but again, different patients with precautions. Okay. Yes, this therapist is one among you only. Anyone who is she? Yes, this is our setup. What we have tried. Okay. Group exercise also we have given general mobility exercise along with the thoracic mobility exercise also. Now, as I told, breath control exercise also we had tried, not only in the stable COVID patient, but who were on non-rebreathable mask or face mask, or the patient who were on nasal cannula also. Bronchial hygiene technique, yes. Posture drainage, of course we have tried, but not to all ward patients. Selectively in ICU patients, some of the patients were very much in need of posture drainage. We have tried also, but the thing is, we have avoided head down position because sometimes head down position can precipitate dyspnea also, because head down position, abdominal content comes up and it will not allow the diaphragm to fully descend. So sometimes it may lead to respiratory problems. So we have not tried this percussion vibration to each and every patient apart from selectively ICU patient. Incentive spirometry, as I told, not each and every patient. Now dyspnea relieving positions. Now this also, when the patient were in wards, not all the patients were having dyspnea at rest. But again, when we have tried a 6-minute walk test or aerobic exercise like continue to walk in the ward whenever you feel like, that time if they were facing dyspnea, we have taught them dyspnea relieving position also. These 4 positions we have taught them. Now, of course, aerobic training we have exactly not tried aerobic training, but again we have asked them to continue to walk in the ward because we have not taken out of the ward or isolation ward to give cycling or what you can say step up, step down or a treadmill, but by giving walking, by maintaining and then improving their functional capacity, we have tried aerobic exercise in one or other way. So we have tried warm up also, marching at the place, walk around the bed also, and asking them to walk inside ward also. So after aerobic exercise, cool down exercise also Now again, the thing is strength training. We have not started actually in the COVID, but we could have started because we thought at that point of time that patient is already deprived of energy. Patient will not be able to do other exercise like not focusing on respiration. That we could have tried like standing toe, standing head down, high sitting knee extension, flexion, shoulder flexion with elbow extension, shoulder abduction with elbow extension, and all this. Wall push up also we could have started. And in the strengthening exercise, our goal always should be to improve repetition rather than increasing weight. So that patient will continue to do that. And again, as I told in the beginning, before recruiting patient for respiratory therapy, monitoring is very important. Again, during exercise also, monitoring plays very important role. So objective monitoring, which you people monitored actually heart rate, respiratory rate, blood pressure, and SpO2 with a finger probe pulse oximeter. And subjectively, what patient usually says while doing this physical exercise, like how they feel in RP score, how they feel, what is their physical exertion level. While doing walking or while doing exercise, we used to talk with the patient that what is the dyspnea level, whether they can continuously talk to us or not, and it's the patient themselves can tell us whether they are having dyspnea, chest pain or not. And during this exercise, if we want to prevent any untoward effects, then we should think that the patient should not exercise with the empty stomach and minimum 1 hour gap between food and exercise. And if we have a close monitoring during exercise, then we can prevent unwanted. And apart from this, supplemental oxygen was already available, bronchodilators and nebulization was almost there, and again, pulmonary team was already there, and physician, as I told, already was there, people. So I think that is what about my presentation, and I want to show you one video. Yes. Yes, I was a little bit faster in the presentation because I wanted to finish in allotted time. Yes, there is a video about role of physiotherapy, which we have done in a Dheeraj hospital. Yes. I think video is pausing, but yes, these therapists are one from. Yes, Mr. Gitau, welcome. I think it is your learn point. So you will be having doubt. Yes.
Just at this point of time, I wanted to actually add one more thing.
Yes.
I know that you people have really done a great work because we know when at what time you were called off, and midnight 12 o'clock I was told that tomorrow onwards I want 10 people to work in the department. Okay, and right now those are giving exams. Okay, okay, and with a single call, all the PGs immediately complained, which I didn't expect, to be very frank. Okay, I was expecting resistance. I was expecting resistance that no, we will not come. But within a call, all of them they came and they did really. I think the intensivists also agreeing and the respiratory my expert is also agreeing that you all did a good job. I do agree, but I still lament something with your point. What is that? Is Sir used the word tried a lot. agreed, but whether we documented in a proper way, if we could have documented in a proper way, our experience would have actually come out as an output which we can show to the others, which probably, yes, they all know they would have done it, but as physiotherapists, I'm still not sure. I think we missed it. I think we all missed it. And I want to tell to all of you, there is something that I want. We are no, yes, we are a teaching hospital. It's known, and we are definitely one of the best teaching hospital in Gujarat, if not in India, definitely. But I want this name to change. We don't want to remain only as a teaching hospital. Please remember PT surplus. We want this to change as a patient-centric, research-oriented teaching hospital. My teaching patient-centric, research-oriented, and then we become a teaching institute rather than we simply remain as a teaching institute. So please remember this. Whatever we do it for our patients, but whatever we are doing it for the patients, whether it is really beneficial or no, I need to come up with something that tells to the world, that I can show to the external world that definitely what I am doing to my patient is effective, or even if it is not effective, I should say it's not effective, so I need to change. And then that itself should teach all of you. That itself should teach all of you that how we are practicing and how we should practice, rather than simply putting a PowerPoint and teaching you everything of what we are should do and we should not do. I hope this sooner or later we change this into a complete this category, because whatever the work we have done, I know 24/7 we all work, but we miss the thing that that could have actually given us a lot of data that we could have given it to the external world, that this is what our experience is. Okay, so please remember this in the coming month.
Faculties. When like Amit was always easy, nice. I want to share an experience. And I was going to the special rooms of ward, and then they were supposed to get discharged in 1 or 2 days. I was asking him, discharge करेंगे हम लोग, ठीक है ना? They used to say, हाँ वो exercise वाले डॉक्टर ने बोला है कल मैं घर जा सकता हूँ. I said, okay, good. If he has said or she has said, okay, we are giving you discharge. So you can see that the time spent more with them and training them for their home activity was more important than medicine, right? So, see that. That is really important. Thank you, ma'am. Thank you, sir. Now I request to Dr. Nikita Patel to give the certificate of appreciation to Dr. Kalvesh Satan. Thank you, ma'am. Now we forward for our prize distribution. So today there is Rangoli competition, and interesting thing in which there is tie between two groups. So we have 2 runner-up group and 1 winner group. So I invite to Anuja Patil and Mahima. This is the first runner-up group. And I request to Dr. Jiju Kumar to please give the certificate of appreciation to them. Anuja Patil and Mahima. Thank you, sir. And now our second runner-up group, Dhruvi Shah and Krishna Chauhan. I invite to Dr. Amit Chauhan to give the certificate of appreciation to them. Thank you, sir. Now our winner, Sakshi Bapna and Sarvari Kalkate. I request to Dr. Asisha to give the certificate of appreciation to them. Thank you, ma'am. And now congratulations to all the participants. And now I like to request Dr. Pinal Modi to deliver the vote of thanks. Thank you.
Good afternoon to everyone. I am glad to be thankful to our guests and speakers, Dr. Aarti, Dr. Amit Chauhan, Dr. Kajay Sanani, and Dr. Rina Gupta. Also, I would like to thank to our Dean Sir, Dr. G.P. Kumar, for support to make this event successful. Lastly, I would like to thank our honorable founder, Chancellor, Vice Chancellor, President, Registrar, all head of institutions, and our faculty members, student council members, and our all students, participants to make this all activity possible and successfully done. Thank you, everyone.
Yes. Please continue.